Hi everyone, thank you for coming. This is just to make sure you're in the right place. This is the Business of Eyes panel session. So firstly, the RANZCO members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islander peoples of this country, sovereign custodians of the country. We acknowledge their continuing presence and their contributions made to the college and the communities we work in. We will respect past elders and communities, and we will continue to live, work, and interact in a respectful manner with present and future elders and communities. The RANZCO Reconciliation Plan reflects the messages of its First Nations engagement. Thank you. So as mentioned, this is the Business of Eyes panel. We're covering business management issues related to ophthalmology. Just one small plug that I wasn't asked to do. If these sort of topics interest you, I hope everyone's a member of ASO. And I think they've got a stand in the trade. Not sure. Go and have a chat, or have a chat to me. I can point you in the right direction. I will very briefly introduce the panel. I won't read their full CVs. They are on the app, should you want to. But just so you know who we've got on the panel. We've got Dr. Ben Clark. He's a member of the Aboriginal and Torres Strait Islander Health Committee. These people are far greater than the CVs I'm going to read out, but I'm going to give you the relevance to today's session. Michelle De Guia is a practice manager and also holds a Bachelor of Applied Science in Orthoptics. She's from Sydney. Associate Professor Alex Hunyor is an ophthalmologist based in Sydney. Former chair of RANZCO Medicare Advisory Committee, which he served for 12 years. Additionally, a member of the MBS Review Ophthalmology Committee and served on the Principles and Rules Committee of the MBS Review. Dr. Carolyn Ross, ophthalmologist. And in 2019, Carolyn was appointed to the Professional Services Review as a panel member. The PSR is an agency that sits within the Australian Government health portfolio, and it was established to protect the integrity of Medicare and the PBS. Its role is to protect patients and community from risks associated with inappropriate billing. Dominique Egan, second from the end, AMA New South Wales, Director of Workplace Relations and Legal Counsel. She leads the Workplace Relations team and provides advice to members on a range of issues, including employment of staff, doctors' contracts, industrial advice to employed or contracted in the public or private systems, medico-legal issues and billing. And Dominique also provides legal advice to the AMA New South Wales Board, Council and Executive in her role as legal counsel. And that leaves me. I haven't left anyone out, have I? I was trained as an orthoptist, but in the last 20 years have worked in accreditation, practice and business management. And I'm the current chair of the RANZCO Professional Standards and Ethics Committee. I'm also a state member of, for New South Wales, of the Australian Association of Practice Managers. So questions. This is a Q&A panel session. So how do you ask your questions? The app, if you've downloaded the app. Also, there's a microphone down the front here, and for those at the back, there's one up a bit higher. But while you're all thinking of your questions, and we're getting used to the app, so I'm not just answering text messages, I am trying to look for you questions. I've got a few questions, so we'll start with those, but start thinking about your own questions. So my first one is for Ben. Ben, some of the practices here are accredited, and part of the accreditation standards is to collect, sorry, I won't move away, to collect demographic data on people that may identify to have an Aboriginal or Torres Strait Islander heritage. What's our responsibility once, as a practice, we collect that information?
Thanks, Donna. Yeah, I'm Ben Clark. I live on Wadawurrung country, which is part of the Kulin Nation. And yeah, I've been asked just to say a few words on what our responsibilities are to our Indigenous patients. And I think I think there's sort of three bits to that. Firstly, there's the question of identification. Secondly, the provision of culturally safe spaces. And thirdly, what you do with identified Indigenous patients in terms of providing them with equitable healthcare and access to our current services. So just with regards to identification, and I'm sure you've all got different ways you do this in your practice, but it's an ongoing issue that you need to be on about all the time. So in our practice, for example, it's on our induction sheet, and we also ask the question directly. But I do know that it doesn't always get done. So it's one of those things you've just got to keep on about, and that applies in the public space as well. The last time we looked at our data at Barwon Health, of all the patients who attended outpatients who were Indigenous, only 40% of them were identified on their referrals. I've never had a referral in private practice where Indigenous status was identified. And you should remember that wherever you are, it's likely that, and these are rough figures, 50% of your Indigenous patients will be getting treated the Aboriginal Medical Service, but 50% will be with their regular GP, with ordinary regular GPs, and those referrals never come with identification. So it is something you've got to be cognizant of and keep on about, because the first bit of getting people to access appropriate care is identification. People are a little bit, can be a little bit reticent about asking the question. We don't really get any pushback from that point of view. Having said that, what you need to do, I think, is promote self-identification. And part of that is actually just providing a practice space that is culturally safe. And you don't really need to do very much to establish what I think is a culturally safe space. And what I have found very useful in my practice, and have had a lot of positive feedback about, certainly from our Indigenous patients, is what you can see there on that slide. And that resource is available from the college. You can get that in A3 and A4 size. So we have that stuck on the secretary's panel there, and you can see that when you walk in the front door. So not only does it say that this practice is going to, well, what it says there really, bulk bill First Nations people to help close the gap. The poster itself and the artwork on it is viewed very positively by our community. The other thing that's quite useful that I think you can get from IEH that some of you might have are the little Toblerone, like the Toblerone shaped desk objects that also ask people to whether they identify as Aboriginal or Torres Strait Islanders. And thirdly, the third thing I'd say about a culturally safe space is a statement. It might just be on your letters or somewhere in your rooms that acknowledges the traditional owners of the land where you are. And those three simple things really do help promote self-identification. So quite often you don't have to ask questions. With regards to the patients that you have identified as Indigenous, there are three practical outcomes, I think, from my point of view, maybe four more broadly, but certainly they're the billing issues. So, I think it comes through time and time again in the research that a big barrier to accessing timely and appropriate care is cost. So it is the position of the college and certainly the committee that we would like to encourage all members of the college to at least consider bulk billing their Indigenous patients, because it's probably top of the list of things that discourage access to care. So that I think is the number one thing when patients are identified. The number two practical issue is close the gap pharmaceuticals, the close the gap PBS scheme. Not all your Indigenous patients will be enrolled, and some of them that are enrolled actually will be tagged as inactive. You can actually access the close the gap PBS through your Proda HPOS account. So if you log into HPOS and you go to your services, there is actually a portal there that actually takes you through to PBS Close the Gap, and you can actually put a name in and see whether they're active or inactive. So that's probably the second thing from a practical point of view. And thirdly is accessing fast-track services. So in Victoria, in all of the 6 PHNs, there are available fast-track access to outpatients and cataract services, and you can't do that unless you've got the patient identified. But once they're identified, then really you can direct patients to receive the appropriate care. And lastly, number 4, I said there were 3, but number 4 is, and if you can, is actually collecting that data, particularly in regional areas, to see whether you can establish whether your group of local ophthalmologists are actually meeting what the sort of projected needs of your local Indigenous community. I'll stop there.
Thanks, Ben. Just in the interest of keeping this flowing, does anyone have any questions relating to anything that Ben just said? No, I'll keep moving. Ben, just very quickly, if we wanted to introduce at the practice a meaningful acknowledgement of country for meetings, how do we find that? Is that something the college does?
You know, an acknowledgement is a fairly simple statement that you acknowledge the traditional owners of the land on which you are or where you are, and that you pay respects to their elders, past, present, and emerging. And you know, I think it's quite good practice to actually have that on your correspondence and elsewhere.
Mm. Yes, would you mind making your way to a microphone though, so the people up the back can hear? Sorry, basically I'm lazy. I don't want to repeat your question. Yeah, don't fall though.
How do we find out who are the traditional owners of the land? Because we've got quite a few Aboriginal patients through Closing the Gap, so that would be a nice thing to do. But how do we find out who are the owners of the land?
You can if you Google it, there are maps that you'll find maps that outline the 50, 60 odd nations and which particular group where you are. It's pretty easy to do.
Is it?
Yeah.
Okay. I'll keep moving. And the benefit of being a chair to a session is for a panel, you get to ask your own questions. So moving on to my next one. Payroll tax is a bit of a hot topic. And I think the biggest thing with payroll tax is rethinking the language that we use around some of the practice components. And one of them is the contracts. And really having to think about the fact that a doctor doesn't have a contract with a practice or isn't part of the practice. It's the doctor contracts the service entity. And with that sort of mindset, I'm just wondering whether there's a place in these contracts, this is the question for Dominique, for a restrictive covenant clause. And by that I mean, can a doctor leave without restriction and work within the next 5 kilometre radius within a certain time period?
Thanks, Donna. Restrictive covenants come in various forms, and so the type that Donna's just described is probably the one that people most commonly come across, and that's where if somebody enters into a contract, if they leave for a period of time within a certain geographical area, they can't compete with the practice they're leaving. They add to the complexity of the payroll tax question, and it's not a straightforward, if you do these things, you won't be found liable for payroll tax. But the inclusion of a restrictive covenant might be one factor that the respective state revenue office looks at to say, well, are these people really running their own business, or are they working in your business? Because it would seem to suggest they're working in your business because you're trying to protect it if they leave. Rather than having that temporal and geographical restraint, what often can serve just as good a purpose, I think, is a non-solicitation provision, which is not quite as restrictive, but it does mean that for a period of time, people can't approach patients of the practice if they leave, and they can't approach staff. So it's usually wrapped up with you can't approach staff or patients or other suppliers to the practice for a period of time. And they aren't as problematic if people do want to protect their business. But if you are truly conducting a practice where people are sharing rooms, sharing overhead, and so they're contracting with the practice for the provision of services, strictly speaking, there shouldn't be a need for any sort of restraint because everybody has their own patients. And if they leave, then one would expect that they would follow that doctor, and the doctor could also ask their patients to follow them. So best practice, if you want to be very as safe as you can be for payroll tax, would be not to include any restrictive covenant or provision. But if you want to include one, then I'd be looking at the non-solicitation type clause rather than the geographical and temporal restraint.
What about if a doctor has that in a contract that's currently in place?
Well, as a lawyer, I always like saying to people, it's always timely to review your contracts. And I do think this is a time when people, if you haven't reviewed your contracts for a while, it is actually very good practice to review them every, I would say, 3 to 5 years. But even if you've reviewed them in the last 2 to 3 years, the payroll tax question is a particular issue in New South Wales, which is where I practice. But I suspect it will be visited upon in other jurisdictions very soon. So I think getting your contracts reviewed, getting some legal advice and also financial advice around, well, do I really need these provisions in my contract? And if I don't think anyone's going to argue with anybody if they decide they want to remove them and reissue the contracts. But there may well be other changes as well that you want to make to the contract. So I'd be encouraging people to go and seek some legal and accounting advice and have their contracts reviewed.
Once upon a time, AMA New South Wales anyway had template contracts. Do they still exist?
We do still have a contract. We don't sell it directly to members because we do think it's really important that people get advice at the same time as getting the contract. So we have an arrangement with HWL Ebsworth Lawyers. You can purchase the contract for $500, I think, yes, $500, and you get the contract, but at the same time you get a consultation with a lawyer. So you arrange that consultation. It can take place virtually or in person, and they provide you with the contract, talk it through with you, and they can make amendments, as long as you don't want to rewrite the whole thing, included within that $500. So I personally think that's quite a good offering. I really would encourage people to have a think about that. We obviously sell it to AMA members, but if you're not a member, we also sell it to non-members. The price is just a little bit higher.
Thank you. While we're on the topic of contracts, does anyone have any questions about that for the panel? Because if not, we'll go straight to my list again. Alex, I believe that there is something coming called, let me get this right, voluntary self-review, which is basically doctors having to review their billing processes and practices. And there's a few item numbers that are up for consideration, one of them being 104. So, yep, we're going straight to the elephant in the room and we'll talk about 104. So I'll be devil's advocate. At a practice, I have a patient. The doctor has said, I'd like to bill another 104 on this one referral. Is that okay?
Nope.
Got a red itchy eye. They had a cataract last time.
Nope, never.
Excellent.
No, I mean,
Shall we move on?
So that's going to be one of the specific focuses. They haven't given any information about how the audit is going to, or sorry, they don't want to use the word audit. Self-review is going to work. But one thing that is completely no-go is any more than one 104 on the same referral. If they have a new problem, they need a new referral.
Dare I ask, are there any questions about 104 use? There you go. can get to afternoon tea early. From the PSR perspective, Carolyn, could you tell us how that is considered, the use of 104?
So when the PS, in the committees I've been involved in, when the PSR looks at whether a 104 has been correctly used, there's each case is assessed on an individual basis, and the question that frequently arises is when people use a second 104 on the same patient. So just because a doctor receives a referral that is for a period after the first referral has expired, it doesn't necessarily mean that they can charge for a new initial consultation if it's for the continuing course of treatment or review of a single condition. There are some circumstances where a new 104 could be considered, and they are if the referring doctor deems that a review is necessary. So that implies it's an active decision on the part of the referring doctor, not just that they're referring the patient on because you've said you wanted to see them again in 12 months. So something has changed and the referrer thinks that the initial condition needs reassessment. And then if the initial referral has expired and it's 9 months since the patient has seen the specialist, then a new 104 could be considered. Things that would be taken into account as to whether that is valid would things that might be looked at would be the referrals prior to that, what the doctor has said, like I'd like to see Mrs. Smith in 1 year, implies that it's a planned ongoing review. The medical record is actually very telling. So to bill a new 104, the medical record would need to reflect that the work involved in a true initial consultation had been done, not that you've just seen Mr. Smith, 18 months after his last glaucoma review, fields tick, pressures tick, everything fine, see you in 12 months. And the appointment book can also be looked at, so you couldn't, if you've had 4 104s booked in a 15-minute period, it might be implied that perhaps the full time spent for initial consultation wasn't spent. But when the PSR reviews it, each individual case is looked at with many different facets. So there are no hard and fast rules, and also it's looked at even if you don't meet the descriptor, what would your peers have thought that what you've billed is sort of fair enough as well. So there is some room for discussion in those cases.
Michelle, if a receptionist or a practice manager, because we've got a few of those here, felt that perhaps a doctor was requesting an item number that was inappropriate, how should that be managed?
Inappropriate as in?
Well, perhaps not to the descriptor. Sorry, not.
I think, in our practice, I train my staff to be the safety net for the doctor. So the team are, I suppose, empowered enough to raise that with me, not necessarily directly with the doctor, but they can do that too. And fortunately enough, the doctors I work with are open-minded enough to listen to those. So I think you have to empower your staff to be your safety net, because at the end of the day, you just don't want to be audited. That's the bottom line.
Dominique, when the self-review or, said the word, it's not an audit.
Yeah, say audit.
The voluntary self-review, say a letter comes to the doctor, should they just go ahead and do it? Should they be contacting advice? Have you got some tips on that?
I think they should definitely seek some advice. So contact your medical defence organisation or your professional association. If you're an AMA member, you can contact the AMA, but seek some advice first, because it quite possibly will be overwhelming when you get it anyway. And so just to have somebody to objectively talk you through it, what are the issues you're looking for and how to complete it, I think that's really important. But also if issues come up, then you've got somebody there who can advise you about, well, what should I be saying in response to this? It's not actually a simple yes, no often. And then what flows from that. So I think it's really important to get people to support you through that process. You're not alone, so make the use of the supports that are available to you.
Great. Does anyone have, so no one has a question on how to use 104s? That's really good. Okay, so what I
All of
thought...
that hard work of
Yes.
yours, Donna, over the past.
Yeah. We've just got all the fabulous, practice managers in the room. So again, Michelle or maybe someone else like to answer this. This morning, the practice managers had a session from Brad Horsburgh with, and he talked briefly about the 104 being once in a lifetime or being attached to a diagnosis. How do you manage that? Or do you not manage that?
Indefinite referrals?
No, just a 104 being for glaucoma and the 104 being for the knife in the eye and the 104 being for a retinal detachment.
It's already currently kind of like it should be that way anyway now with the descriptor. So it's a single course of a condition. So if you have been referred for glaucoma, that should be a lifetime. So it is what it is now. So
if anyone had any questions, I know some people had a few questions on that. Indefinite referrals. Whoever would like to answer this. Does a practice have to accept an indefinite referral?
yes.
We pass it along, see how many yeses we
Yeah,
can.
you have to. I mean, it's the decision of the referrer, not you as someone who's being referred to. So it's their decision whether they only want the referral to last 3, 6, 12 or indefinitely. So, and you truly can't reject that.
Yeah, it can even be a particular number of years. It doesn't have to be sort of 12 months or indefinite. And as Michelle said, it's not it's at the discretion of the person doing the referring, because it's they're deciding what's appropriate for the patient, for their patient.
Any questions on referrals? You're a quiet bunch. So basically, if there's a referral written to treat their glaucoma, but you notice that they've got a leaky macula and you want to do a 104, yeah, that's where we're going with that question.
Yeah, I mean, it is fine. It's obviously problematic for a number of reasons, because referrals often don't say what the condition is for, which they technically should, and also there may be some resistance on the part of patients or referrers or whatever to get that second referral for the additional diagnosis, but that's the way that it should be done.
What about the referral that comes, dear doctor, please review Mary's eyes? And it's another practice. It's addressed to another practice. How should that be managed? Michelle, she wants to answer that one.
Even if it's addressed to another doctor, as long as it's a referral that hasn't been used, any ophthalmologist can use that. So the patient actually has the right to use that for any ophthalmologist that they choose. But the referral needs to indicate the condition. So you have to have the condition written on the referral. You can't just say, just a general review. So
they do frequently just say.
They don't often have and perhaps the GP doesn't know what the condition is. No. So.
But if we want to follow the letter of the law, it actually needs to have the condition on there.
I must say, practically, I would have never contacted a GP that's to then specify the condition and reissue the referral. I think that would be, like, I agree that that's what they should do, but in practical terms, I would never have rung a GP to say, please specify the condition.
No.
Look,
So
I
you
think
can
it's
just accept
important
it.
for the indefinite ones, definitely. Because an indefinite referral, well, is indefinite. So if you come in with another condition and you want to charge a 104, you won't be able to charge a 104. It doesn't matter if they come for glaucoma and then next time they come for cataract. So it's
So-
got to indicate it.
Carolyn or Alex, if you, with regards to the 104, if you write a letter back to the referring person saying that I have discharged this patient with glaucoma back to your care, and then, you know, they bounce back again, can you charge them a 104?
So my less educated reading of things is that technically you may, but Carolyn
It would
brought me
depend
up to
on
speed.
whom you discharge them to. So obviously you can't discharge them. You might write in the letter that you've discharged them back to the care of the GP. Obviously the GP can't take care of the glaucoma. So I would suspect it would be up for discussion that if you're just including that line in the end of your letter so that you can justify generating a new 104, that perhaps wouldn't be taken into account. If you've, say, treated a retinal detachment and all that is completely finished, and then you're discharging them back to the care, the retinal surgeon doesn't want to see them again, and then they came with something else, and that would generate a new 104. I think also it depends, say, glaucoma or diabetic retinopathy. It would depend also what you'd written in your letter and what's in your medical record, and again also what was generated when they reappear with a 104. So if they reappeared with a 104 and you've, say it was glaucoma, and you've completely reassessed them, you've done gonioscopy, you've done pressure tests and whatever else you want to do, so you've done like a complete initial examination as you would for a new patient, then that might be taken into account, that could justify a 104. But I think just writing, I've discharged them to your care, won't necessarily mean that you can, a new 104 would be justified.
Dominique, what about the issue of duty of care in relation to handing back someone with glaucoma back to a GP? I'd hate to think that was...
I'd like to think it doesn't happen,
Yep.
but even if it did, then I would have thought the GP might get in contact just to clarify exactly what was intended by that correspondence.
Yeah, so there's no point gaming the system in order to get a 104. You need to do what's clinically appropriate.
And I think there's that difference, as Carolyn said, between something that's clearly chronic and something that's episodic. So patient comes along, they've got a retinal tear, you treat it and you say, see your optometrist at the usual sort of interval, then I think you can say, I'm done with them. But if they've got chronic condition, AMD, diabetic retinopathy, glaucoma, then once that diagnosis has been definitively made, then you can't, unless it's something like a diabetic with no retinopathy, and you say, I'm sending them back to the optometrist because there's no active issue.
Any questions about this?
Question. If you send the patient back after a few no-shows, what then? And then they get sent back again.
So I think it might be, the management of the patient that doesn't turn up. Yep. And so Dominique, you may also like to look at this in duty of care in a patient that's non-compliant with turning up to their appointment.
Yeah, so I guess that is one scenario where a specialist might send a patient back who requires ongoing care to their general practitioner to say, this person has not attended on a couple of occasions, I'm discharging them back to your care, perhaps you need to find another specialist to take over their care, or contact me to discuss once you've spoken with your patient what the issue might be. But if they then are ultimately referred or sent back to the same ophthalmologist that they've seen before, then they couldn't charge another 104 because they'd really be continuing the care that they'd commenced before, in my view.
Thank you. At what point should a practice stop trying to contact a patient that hasn't turned up? What's appropriate to follow up a patient that's a serial do not turn up person?
In part, it depends on the nature of their condition, and they may not realise that there's some particular urgency for them to return. So in those circumstances, I'd be trying to contact them on a number of occasions over a very short period of time. And if you can't contact them, again, part of the benefit I always see of being a specialist is hopefully the GP involved in that patient's care as well. So to contact them to find out, have I got the wrong contact details or what have you for this patient? I need them, they haven't come back for their appointment. But I think trying to contact them on at least 2 occasions and then perhaps in a different way. So if you've been trying to contact them by phone, then perhaps sending some correspondence to follow up just in case there is that issue about contact details. You don't have to follow them up indefinitely, but I think you need to demonstrate that you've made a number of attempts, and I think always then going back to the general practitioner to let them know that that patient hasn't returned so that they can also make some inquiries.
Any other questions before we move on? I'm getting some questions through the app about referrals, 104. I've got someone, yep. Just yell it out, Christine.
Can I just ask maybe Dominique, with the no-shows, we do try several methods, so email, phone, whatever we've got. And after the 3 attempts, I usually write a letter to the patient explaining the importance of follow-up, and then I copy it to the GP and or optometrist.
Yep.
Is that reasonable?
Yep, that sounds great.
Any other questions about duty of care? You can call them out. I won't make you come to the front. Yes?
What about specialist to specialist referrals? Say if an optometrist who refers a patient for glaucoma, they're seen in a practice, and then the specialist refers to another subspecialist, for example, for ongoing care, but also for subspecialist expertise. Is that appropriate to charge the 104 for that?
Yeah.
Yeah, that's fine. You do have to be careful with because they certainly do look at the number of internal referrals within practices. So you need to document the reason for referrals. Obviously, if it is for different subspecialty expertise, and that's fine. But obviously, it's only valid for 3 months, and you will get looked at if you're in, say, a group practice and there's a very large number of 104s being generated through internal as opposed to external referral. It's not always an inappropriate thing, but it is a very easy metric.
On that note, there's a question that says, can a specialist write an indefinite referral?
No.
No. Okay. Alex, this may be for you, maybe for no one. Will OCT ever get a rebate? So everyone wants to ask that question.
Yeah. So look, the only, in short, no, not in any general sense. Well, I don't know. I've only been trying for 15 years, so maybe I'm just not any good at it. But in fact, the only reason that the current OCT rebate, the initial 11219, exists is just because of an idiosyncrasy of the PBS, not even the MBS, and that's very restricted for a reason and won't change.
I'll go to this next question, and anyone can grab this. I have a feeling it might be for Dominique. Is anyone on the panel able to explain the issues around tenant doctors and tax implications with the ATO deeming the tenant doctors as employees, leaving us liable? If that person is here, we might just need a little bit more explanation. I guess.
Is that a payroll tax question? Yes.
It's not the ATO then, it's OSR.
Yeah, so the payroll tax is determined at a state level. So depending what it's called, in New South Wales, it's the Office of State Revenue. In terms of I guess it's sort of the topic of the moment, and it's a little bit, it's still a little bit uncertain as to what is going to happen. The optical superstore decision in Victoria was the decision that sort of has thrown it all up in the air a little bit. And that wasn't a decision about doctors, and I won't get into the legal technicalities about appeal points that were taken and appeal points that were not taken. In New South Wales, there's a decision of Thomas and Nars that a lot of people, I think, hoped that the appeal would result in a different outcome. And now I think there's another appeal underway. My view about that arrangement is that they were probably always at risk for payroll tax even before the optical superstore decision. And that's because I've always tried to explain this to people about not just payroll tax, but payroll tax is certainly the best example of one of the taxes that might apply. When you're conducting a practice, are people working in your business of providing services to patients? So are the patients of the practice? They're not patients of the individual doctor. That sort of arrangement, even prior to optical superstores, in my view, was at risk for payroll tax because there are deeming provisions in the Payroll Tax Act, and certain people can be deemed to be employees, for want of a better word, depending upon the nature of the arrangement. If you're conducting a practice where your business is providing overhead to the other doctors in the practice, and they are each conducting their own individual practice, the risk of being caught for payroll tax and other purposes, the tests are all a little bit different, is much less. I can't give a guarantee that it won't happen. I think there's a much greater risk after optical superstore. In New South Wales, the Office of State Revenue has prepared a draft guidance note, which we at AMA New South Wales provided some feedback on, and I suspect others did as well, and that's gone nowhere. I'm not sure whether that's because of the recent High Court decisions around you actually have to look at the terms of a contract before you make a decision that somebody isn't what the contract says they are. But again, with the change of government, I don't know what's going to happen with that either. But I think the safest model is the model whereby people are practicing from the same location. They've got their own patients, they're conducting their own medical practice, they are contracting with the practice to acquire services to help them run their practice. I don't know if that answers the question, but I hope it
Did that answer the person's question? We won't go from referrals just yet because there's one more. So if a doctor writes a referral and they retire, how long does that referral last for? Does it expire when the doctor retires or not?
I think that's one of those kind of getting different answers from Ask MBS when because
what time, what day,
I was one. I mean,
Whether is it? Yep.
staff in one of the practices that I conduct my own practice at inquired once about a referral that had been written by a doctor who's now deceased, and Medicare said it's still valid, which I found a bit curious. So I think it's hard to know. I mean, I think the ideal situation is you just get a new referral. Is probably the most.
It would be good practice to not have a communication channel with the current GP. Yes, no? Yeah. So hopefully that answered that question. Carolyn, I'm jumping here. Does the PSR just knock on a doctor's door one day?
No.
Right.
So there's various steps that are taken initially by Medicare. So if your billing practice shows that you're having a trend that is different from your peers, then you can be sent a letter just to ask for a bit of self-reflection, and then your pattern of practice might be reviewed. If the Medicare decide to send it on, or actually before they send it on, you can be given again, it's the jargon, it's a personal review thing, so you get a period of time where you can self-reflect and look at your billings and think about whether you're complying, and then they'll look at it again in a year's time. And so you get sort of, I think, a few hints that things are coming your way. If the behaviour continues, or the Department of Health Medicare still have concerns, then it can be it's sent on to the director of the PSR, and they have a look at it and decide whether there's a case to be answered, so that the director of the PSR might decide there's nothing to see here, it's all fine. And if the director decides there is a case to be looked into, then there's lots of discussion with the doctor of concern, and might be then agreements come that they pay back a certain amount of money if they've admitted to inappropriate practice or discovered that they've had inappropriate practice. And I think it's something like 90% of the cases are resolved at that point, and then only about 10% go on to being assessed by a committee.
Has there been a change recently of specialists being considered more by the PSR, or is...
My understanding is that most of the cases for a long period of time have been looking at general practitioners, and now they're moving a little bit more to looking at specialists, and also anyone that's got a MBS item number, so optometrists, physiotherapists, anyone that can bill on Medicare.
I've just had a question. The PSR stands for Professional Services Review Panel. So hopefully that answers that question. Okay. Does a referral expire before it's used? Michelle, this is totally your question.
Is that on? Yep. So usually you've got 1 year to use it from the date that's on the letter, and after that they'll need to get a new one. Is that what you do?
So it is activated on the day they're first seen. Is the best way. Okay, I thought we'd have another 104 question. Can a 104 be used for an urgent patient without a referral, or can you only bulk bill? Do you want to talk about emergency?
It's a if it's an emergency, and obviously you need to be careful to not call too many things emergencies, then a referral's not required. There's no, and a 104 can be charged, and there's no stipulation about the way in which you bill the patient. You can bulk bill them or do whatever you would normally do, but then a referral needs to be obtained for subsequent consultations.
Yep. So emergency can only be used once.
Yeah, and there needs to be clear notation on the invoice or receipt to say, we just write emergency attendance, no referral.
I thought we would, yes. Yeah, Jody, look, we've also had that advice. Is that Jody up there? Yes. Yeah. That apparently you can still use it if it's current, if the information within the referral is current. But again, that's if we ask MBS now, tomorrow, we may get a different answer.
It'll get rejected by Eclipse.
I'm not sure who'd like to answer this question. So the patients of the practice. So does it mean that all urgents who see anyone should be seen by an employed doctor? Do you understand where that question's going? So should there be, so say you're a practice that sees urgents, a GP rings up and you'll see an urgent. Is that patient owned by a doctor or the practice? And do we have, I think there's payroll tax being seen as, I think that's where we're going with this. Are they seen as an employed doctor?
No, it will depend upon arrangements within the practice. So somebody could be referred to a doctor in a practice and decide they want to see somebody else and use that referral. That doesn't make them the doctor to whom the referrals address their patient or a patient of the practice necessarily. It will depend upon how the practice deals with that. So if patients are referred to the practice as emergencies and they allocate them, and then their arrangements going forward are once you've seen that patient is considered to be yours, then that would be how it would be dealt with. And even, I just want to clarify, that doesn't stop people if somebody's on leave or somebody needs to be seen urgently, and so they go and see another doctor within that practice. That doesn't blow my hypothesis out of the water that you would still have doctors running their own practices. Part of the benefit of sort of being co-located is that people can cover for one another if somebody's on leave or what have you. But it would be at the end of the day, if, for example, Alex walked out tomorrow and he said, well, this is my cohort of patients and we're all going together, there'd be no dispute about that.
Should I bring it up? The use of 111. Carolyn? Brad had a really good example this morning of someone that lives, 200 kilometres away, and they're booked in 12 months and they're coming after their cataract 5 years and they have a YAG. What's appropriate for the use of 111? What's not appropriate for the use of an unplanned T8 item?
Look, I think the wording of a 111, I think, uses the word exceptional circumstances. So I think you just have to look at the wording. If, again, in my experience when you're looking at these things, there's no hard and fast rules as to whether if they came with PCO after a cataract, you could possibly argue that that's a single course of treatment, in that, a PCO following cataract surgery is a common occurrence, and so that's part of that treatment course with the PCO. If you'd noted PCO in your previous examination, then it's not surprising that you might need to perform a YAG capsulotomy at a subsequent event. So you'd have to look at the details of the case, but the actual wording does use the word exceptional for 111, I'm pretty sure. So,
and just from a purely pragmatic perspective, the rebate's the same as the 105. It's just not worth creating that much trouble for that, So I think you want to use that very exceptionally, very rarely.
So we're going to stick on the referral topic a little bit more. There's been a question that is, I'll paraphrase, a receptionist, I guess, is getting feedback from a patient that's asked to get a new referral, and they're saying, well, you just want a new referral so you can charge more. Advice to reception staff, how to respond to this, down to Michelle. Yeah, that went down to the keeper.
I always say to the team that whenever a doctor asks you to, or when we charge a patient, the decisions should always be a clinical one, never a monetary one. So if you want a new referral, you can ask the patient to get a new referral, but if it's just about, say, if it's just you can generate a 104, so don't game the system. If it's just to generate a 104, then don't do it. Is my advice.
Generate a 104.
If you're just asking patients to get a new referral just to generate a 104, just don't do it. It's got to be a clinical decision, not a monetary one.
Yeah.
Yeah. So
But that question actually implies that the patient may have had the experience of getting another referral and being charged an increased fee, which Carolyn and Michelle have already highlighted is not how it works. And it gets back to that point that a new referral does not start a new single course of treatment.
Yeah. So it comes back to the descriptor, wherever that is. Back here. No, one more. It won't go back. Just while I'm trying to make the slides work, there was a comment that a 111 is the same rebate as a 105, but you can't charge a 105 with a T8.
That's right, yeah.
So you
But
just don't charge it.
Yeah, that's really the purpose of it, existing is that when they introduced the provision that 105 can't be charged, can't be co-billed with a T8 that has a schedule fee of $300 or more. At the time, the schedule fee for an intravitreal injection was $300.85. Total coincidence. Then they did make that provision. They did Gazette 111 for the reason that there are exceptional circumstances in which it's legitimate to do that. But as I said, it's not worth
Do it.
dying in a ditch.
I like this one. What is not normal aftercare? I don't know who wants that.
I'm gonna. Ben's
There's some body language going on, Ben. No, Carolyn? Anyone?
I think it's a clinical decision, not a monetary one.
Ah, nice. I see what you did there. You put it
That's-
back to everyone else on the panel.
It's a clinical decision, not a practice manager one.
I think things that would be considered would be what's your normal practice. So if your normal practice is to see a cataract day 1 week, one month, and that's your usual practice, and your peers would consider that to be a normal practice, that would be something like that. But if you needed to see them 5 times in the first week because their pressure was terrible and that's not your usual practice of follow-up and that's not the usual practice of your peers, then that would be, I think, probably considered a reasonable thing. So what's your pattern of practice and what would be considered a reasonable pattern of practice by your peers?
Also bearing in mind that you've got a patient there who's having problems, who's coming back multiple times, and as Michelle said, it's not driven by finances, but the patient is also going to perhaps be feeling a particular way about being repeatedly charged because you're bringing them back to deal with an issue, not necessarily of your causing, but
To be a decent human being.
But some people charge a bulk, not normal aftercare 105. So bulk bill them. So there's a charge to Medicare, but not to the patient,
which is
fine.
perfectly reasonable. Yeah, absolutely.
Okay, I'll try and make a segue, but perhaps not. Dominique, maybe I'll again paraphrase this. HCCC rules and collusion of doctors charging that are in a group practice. Do you want to give us a bit of a statement? Would that, so we tick that box?
So the ACCC governs competition, and so doctors, unless they're really really employees, let's not speculate about whether they should be or they shouldn't be, but if people are employed by a company, then they're not competitors. But for the most part, certainly ophthalmologists will not be working within the same entity. They will be working as a sole trader, so as Dr. X, or through their own practice company, and they will be competitors with one another. So they can't sit down at a practice meeting, for example, and say, I am going to charge this for a consultation. Do you all agree? Will we all charge the same thing? Don't do that. That said, it doesn't mean that people can't go to conferences and talk about what they're charging for certain services. You'll go to some conferences where people will actually be talking about benchmarking and all those sorts of things. Accessing information or even telling somebody what you've decided you are going to charge isn't anti-competitive. Is that you can't sit down together and decide what you're going to charge. And the market, which is what the ACCC is trying to protect, by and large will dictate that most people will be charging more or less the same fee, because if people come and say, well, hang on a minute, my friend went down the road and they were charged something else, then that doctor might find they don't have as many patients, for example. So you can find out what other people are charging so that you can make an informed decision about what you're going to charge, but you cannot sit down with your competitors and make that decision together. And your competitors are your colleagues.
That was
Can I quickly ask you a question then? If you're in a group practice, patient's been coming in and having, say, injections for years and years, you go away on leave and someone else sees the patient as, in a locum kind of capacity, and, we've all got our own sort of fees or whatever, and the patient says, well, my usual doctor charges me whatever, is that okay?
Yeah, someone could make a decision to say, well, then I will charge whatever that doctor charges. And they may well say, well, when your patients come in, actually, I will just charge them what you normally charge because it's just easier for everybody. That's not deciding that's what you're going to charge all the time. So if there's usually a discrepancy, one would expect the discrepancy to remain if they were treating their patients as opposed to covering somebody else's while they were on leave.
So does that mean that if you've got a group practice, the doctors should charge different amounts? Is there anything that safeguards you from that ACCC ruling? Does that
Don't have meetings of your practice, minutes of your practice meeting where you've all decided what you're going to charge together would protect you. But just to not have those discussions, I don't think you need to have differentiation. As I said, the market will set the market. If somebody goes out first and says, this is what I'm charging, then that will, probably be what everybody else ultimately adopts. But also, I think it's specialist practice is not quite as commonplace as it might be in general practices where they have up what their fees are for consultations. In specialist practices, that's not usually, well, people can tell me if I'm wrong, but it's not usually how it's done. So other patients who come in and are sitting in the waiting room wouldn't necessarily know what somebody else is being charged. And general practices, just so people know, there's an authorisation that permits them to collectively set their fees because that's seen to be in the public interest so people can access general practice services knowing what they're going to be charged. So there's a difference, and a number of specialist groups have sought authorisation from the ACCC so they can collectively set fees, and the ACCC has consistently said no to them.
If we circle back to not normal aftercare, if Carolyn does a cataract and then she nips off to Hawaii and Alex is seeing post-ops, can Alex bill?
No.
Yep.
That was easy.
What if it was an unexpected, you've seen, it's an unexpected post-op review of somebody else's patient during the normal after care?
Well, then it's the same as if it was your own patient because you're acting as if you were that doctor.
So you can or you can't?
You can, yeah, it's fine. Sorry, can you either speak
So
up
if
or
it's
use a
an
microphone?
acute problem, it's at a different practice and you've seen a post-operative patient, can you bill?
So an acute problem.
Is that right?
Yeah. So really, it's it's a matter of whether or not it's normal aftercare as opposed to whether they're in this practice or that practice or whatever. So if the patient's presenting with an acute issue that's not something that's normally expected in the post-operative period and you see them, then that's fine. And if they don't, come along with a referral, you would hope that they would. But if they don't, and it's a truly, emergency problem, then you can use a 104 and write emergency attendance. But yeah, sorry, just to be safe though, you should write not normal aftercare because I have had someone ask me that question where they're in a situation where even though they'd never met the patient before, they had a claim denied because Medicare said, no, well, this patient has recently had surgery and they're in what we would consider to be an aftercare period. So you do need to write not normal aftercare, even if you were not the one who did it.
I think this question means, can you charge an OCT, so a non-MBS item number, if you're bulk, so an OCT, for example, if you're bulk billing an injection? So this is GN 717 or something or other.
Yeah, so it's a non-MBS item. So yes, it's also diagnostic. So you can you have the discretion to you can bulk bill one particular thing and not another for if it's consultation or diagnostic. But once you get into T8, which is the procedurals, If you do more than one T8, then they need to either be all bulk billed or not. You can't sort of pick and choose with those.
We have had a question about review after 9 months. Who'd like to take that? What is the definition of a single course of treatment? We had a feeling that might have been a question.
So it wouldn't necessarily be guaranteed that you could charge a 104 after 9 months of treatment, after a gap of 9 months. It would depend again on whether the referrer had deemed the review necessary, as opposed to just generating a referral for a 104. So it wouldn't be guaranteed that just because you have a new referral and you haven't seen the patient for 9 months that you could charge a 104. All those other things I said before about the assessment, what's actually done at that review, and what's recorded in the medical records would all be taken into account. So you couldn't guarantee it, but each case is assessed on its individual merits or whatever.
We're going to go back to not normal aftercare, sorry, but we'll be experts by the end. Are the RANSCO post-operative care timeframes the same as Medicare's, e.g. 42738 has a 7-day post-op period? Anyone?
Well, Medicare has consistently declined to say what it thinks they are. So that's the reason that the college came out with those guidelines. And I think that by the same principle of what people have said about various other things, if you're doing something that is, considered to be what your reasonable peers do, and in this case particularly, you've got a guideline from the professional organisation, then I think that's fine. So you can just use the RANSCO guidelines.
Oh, the questions went. I did want to ask, sorry, bear with me, I'm trying to multitask. Carolyn, I think this is how much might the PSR review mean? Is it the whole amount or more like a percentage? Is that, I don't know if the person wants to say, that might be when someone's paying back for incorrect billing? Is there any formulas or?
Yeah, there are formulas. So when certain item numbers are referred to the committee, we're given 30 randomly selected medical records for that item number. And during the course of the review panel, each of those 30 cases are discussed with the doctor, and a decision is made for each of those item numbers whether inappropriate practice is being or whether there is inappropriate practice on each of those item numbers. So if all 30 item numbers were deemed to be inappropriate practice on each occasion, then we don't make the determination, so that the committee refers that on to the report goes to the determining authority. And my understanding is if 100% of the cases are deemed inappropriate practice, then the doctor has to pay back 100% of all those item numbers for a 12-month period. So if all your 104s were deemed to have been billed inappropriately, then you would have to pay back every 104 for that entire period. If we say that 20 were deemed inappropriate practice and 10 were okay, then there is some complicated formula, I think, that the determining authority applies, so that you don't. It's actually would work out less than 2/3 that you would pay back. I think it's a complicated nominal, so you pay back a proportional amount.
Who asked? T8s is all the item numbers starting with 427. Is that right? Is there some others?
It's a lot of.
It's a category in the book.
Yeah, it's a category, so it's procedural. Essentially, anything that's procedural. There's a number of different sort of sections, and some ophthalmologists, for example, oculoplastic surgeons will use numbers that are outside the 4. They'll use 4 5s and things. So yeah, it's just the by far the majority of them are in the T8 subsection that's ophthalmology, and then there are a few outside that get used.
I don't know, you are Rain Man with the MBS review, so you might be able to answer this question.
That's Pete Sandwich's expression, Rain Man. I object to that.
Can 18240 be used for a subconj local anaesthetic?
No.
There you go. That was see, you knew that.
It's not. It specifies.
What's that? What is that
I
item
think
number? I don't know.
It's the item number for peribulbar or retrobulbar injection, and I know that people have suggested that in the past, but subconjunctival injection does not meet that definition.
Okay, we're just going to go back to, I'll give you this specific question. Can you charge a full fee, so I guess a private fee, 104, and bulk bill a non-T8, such as a B scan? Or do you have to bulk bill, my app, I guess, do you have to bulk bill at all? Might have been the question.
No,
So-
that's fine.
Yeah, so it's GN717 if you read the MBS review for that person after I just called someone else Rain Man.
Yeah, so essentially, if it's only when you get to procedural things that you have to potentially bulk bill everything. Otherwise, it's at your discretion for each individual item number. And the other thing to point out that a lot of people get confused about too is that the multiple procedure rule only applies to T8. It doesn't apply to diagnostics. So if you do biometry and a visual field and a fluorescein angiogram, the patient will receive 100% rebate for each of those. Whereas if it were 3 procedural things, then it's 100%, 50%, 25%.
Do you have to get a visual field test before the patient has a blepharoplasty?
Sorry, can you?
Do you have to have proof? I think they're asking, do you have to have proof that they've got restricted visual field, correct me, the person that's here, to prove that the blepharoplasty can be done with an item number through the MBS?
No, that was quite sort of controversial in terms of the change of the wording, and I can't remember exactly where it landed. We had quite a bit of correspondence about that, but essentially it's pretty much back to where it was before, so you don't have to rely on visual fields alone, but if you're not using fields, then you really do need to have photographic documentation. You need to be able to demonstrate, because obviously you've done a blepharoplasty, so the evidence is gone. So you need to have preoperative documentation other than just written notes.
If anyone's got a question, just jump ahead, otherwise I'm running through the app. A practice manager at a group practice that I work at won't let me set my own fees. How should I deal with that? Dominique?
Michelle.
Yeah, I think that's...
Michelle.
Michelle.
You should be, I mean, the way we're set up, you should be able to ask them to what fee you like. You should know your own value, really.
So when we have a new doctor, it's here's the XYZ, this is how you log in, how much, what are you charging for a 104?
Yep.
It's always a bit hard because if they're brand new, they don't know what they should be charging, but that should be part of the onboarding. Doesn't answer the question for this person, how are they going to deal with this difficult situation, but...
Take them out for coffee.
Does the practice manager in that case have a case to answer in terms of restraint of trade or something? I mean...
Do they, Dominique?
I don't think so. Again, it would depend on the nature of the contractual arrangements, I guess, at the practice about who had authority to do what, but it would be unusual that there would be anything that would be binding anybody to what somebody else determined. It's also, I think it's also, I mean, just to, while we're talking about Medicare and what have you, whatever item number is charged for a service is the doctor's decision, and therefore that sort of really necessarily ties it to then what's the overall fee going to be? Is it going to be a bulk billed service? What is the private fee that's going to attach to that? So I think if people aren't accepting responsibility or aren't being told they're responsible for what is charged, then they need to learn pretty quickly that it is, because at the end of the day, certainly for Medicare purposes, the buck stops with the doctor, not with anybody else.
Can an orthoptist charge, I think the question said a visual field, or it could be an A scan, if the doctor's not on site? So bring that back to it. It's a diagnostic, but it's being done by a technician or an orthoptist. Is that okay?
As in the orthoptist is
So just
receiving
say
a payment?
the patient's having a visual field, but doctor's doing surgery.
You can do the test, but essentially the patient is not really paying for the test, they're paying for the doctor's advice. But that's how we would run. So the orthoptist would do it on a Tuesday, the patient would be seen by the doctor on Thursday, the doctor will review that test, and the patient will be billed on that Thursday, not before.
And that's, I mean, that's an issue that's not really clear. It's, doctors are getting rebated for the point and shoot, not the interpretation. And that's, I mean, that's how it should be. Here's a general question. What does the panel think is the future of Medicare?
Read the news lately?
So we're not, no. Come on, Alex, you must know
This will end up
people
in the
that know
paper.
things.
Yeah, I think, well, if you're going to speak about, you know, $8 billion, I would only say that there were some aspects there that I found totally unsurprising. However, the magnitude that was being quoted seemed way beyond what I would have expected, and there's been subsequent coverage, unfortunately, not in the same form as the original stories, because it's not, you know, not going to get as many clicks, but essentially indicating that that number is a gross overestimate, which is completely lacking any data to support it. And quite recently, various government bodies estimated that it's probably more in the vicinity of $2 billion. I'm not going to apologise for colleagues who are doing the wrong thing, because clearly $2 billion is still a huge amount of money. But I think that there's been a lot of sensationalisation of that. But I think these things are always a wake-up call for everybody to re-examine their practices in that regard. Yeah, and as Carolyn said, traditionally audit and compliance type activities have been very much directed at GPs, because that's sort of what the Department of Medicare have known, and they're much easier things for them to understand and much easier metrics. But now they are sort of getting more into looking at specialists. In terms of the actual future of Medicare, I think in its current sort of fee-for-service model, I think that it's I think that a major overhaul is just been in the too hard basket for a very long time. So the short answer is I'm not that optimistic about it remaining in that sort of current form, but nobody seems to be coming up with a better solution at the moment.
Okay, so we have 5 minutes left. So if there's a question from the floor that someone wants to ask, please ask. Otherwise, I'll continue with the app. And there's a few, I'm not going to get to them all, I'm sorry. I do like this one though. So new patient arrives with an indefinite referral. So can that, is that appropriate?
Yes.
But how does the GP know that they've got to
it's got to say the condition on there. So you can't just say this is an indefinite referral for Mrs. Smith. It's got to say this is an indefinite referral for the condition of Mrs. Smith and what you want to review. So you can get another referral if Mrs. Smith develops another condition.
I can't say I've ever encountered that, but the one circumstance, I suppose, where it might be legitimate would be if the patient had an identified chronic condition. The GP had had correspondence from the previous doctor, and Mrs. Smith said, I'm never going back to Dr. X for whatever reason. So the GP could actually write you a referral that said, could you please look after Mrs. Smith's diabetic retinopathy? This is an indefinite referral, but I've never seen that.
There's something here that I think is more of a comment, and I think you know this. The item 111 doesn't have exceptional circumstances written in the descriptor, and this is quite confusing for ophthalmologists. I'll take that as a comment.
Yeah, so that's in the explanatory notes, which is another, just in general terms, you do need to always look, and some of the items, particularly the consult ones, they might have 5 applicable explanatory notes, and you do have to be familiar with those.
What are the consenting obligations for additional tests? So the practice managers just heard about, you know, Mr. Smith came in and didn't realise that the argon laser was not part of a standard consultation. Michelle, look like you're ready to answer that one.
We always quote a patient before the procedure's done, so the doctors will make sure that the doctors then just don't see the patient and jump straight into the argon. So the doctors in our clinic pass the patient on back to the orthoptist, or the orthoptist actually, upon seeing the patient, makes the decision, you may have this procedure, we're not sure, but this is what it might cost. Get them to read through the risks and complications, sign the financial consent, and then you'll reduce your problems at the front desk. When they were expecting to pay $150, and next thing you know, they're paying $1,000.
There's some specific ones. I'm not sure if the panel will be able to answer this. Can an eyelid papilloma and benign cyst be removed on Medicare? I guess, does that mean together? Does anyone know the answer to that?
So what was the question again?
Can eyelid papillomas and benign cysts be removed using Medicare item numbers? Not sure.
You'd have to, there's skin, you'd have to look at the skin lesion item numbers, which are not in the ophthalmology section, and they're actually quite complicated and depend on all sorts of things to do with size and sending to pathology and so forth. But it sounds, if it's pathological as opposed to otherwise, like cosmetic, then I don't see why not.
And that was another question. Do you have to send benign eyelid lesions off for histology to charge the eyelid lesion item number? I guess if it's in the descriptor, it's in the descriptor.
Yeah.
1 minute. No other burning 104 referral questions. I just wanted to take the last minute to thank the panel who've answered lots of questions, you know, on the fly, which is fabulous. So thank you, Michelle, Dominique, Ben, Alex and Carolyn. Thanks for coming.